territory of Huichin, the ancestral and unceded lands of the Muwekma Ohlone tribe,
who are the successors of the historic and sovereign Verona Band of Alameda County. This land was and continues to be of great importance to Native people.
We recognize that every member of the community has benefited
and continues to benefit from the use and occupation of this land.
Consistent with our values of community and diversity,
we have a responsibility
to
acknowledge and make visible
the university's relationship to
Native people.
In an effort to support and build community among Stanford members who are engaged in health equity, Stanford Medicine's Office of Faculty Development and Diversity has launched a Health Equity Action Leadership Network, or the HEAL Network, along with a series of events throughout the academic year. As a member of the HEAL Network Steering Committee and on behalf of OFDD, I'd like to welcome you all to this HEAL Network event, Health Equity Research in the Black Community. The HEAL Network aspires to provide health equity research collaboration opportunities, foster community and networking among Stanford affiliates engaged in health equity, offer education about numerous health equity topics, unveil on equity and injustice, and equip Stanford community members with tools to transform health systems. Today's event will feature 4 brief presentations, followed by an open question and answer session in a fireside chat format. We'll be recording the fireside chat, but we'll stop the recording once the question and answer session begins to support an open discussion. Feel free to submit questions via the Q&A feature, and we'll answer those questions after the initial presentations. We'll have 4 faculty who will share their experiences with health equity research in the Black community. I'll take a moment to introduce our 4 presenters before we hop in. First is Baraka Floyd. She's a clinical assistant professor and associate chair of diversity, equity, and inclusion in the Department of Pediatrics. She was appointed as medical director for Peninsula Family Advocacy Program in 2020, which is a partnership between Lucille Packard Children's Hospital and the Legal Aid Society of San Mateo County that addresses legal issues that may negatively impact child health. Dr. Floyd championed the rollout of an inpatient food security screening pilot at LPCH, obtaining the buy-in and the input of patients and family services, social work, nursing, case management, clinical care liaisons, and informatics. She also developed a postpartum perinatal depression screening and universal social determinants of health screening protocols for all patients that can be integrated into EPIC. Our second speaker is Donald Golden. He was born and raised in Berkeley, California. His mother's from Louisiana and his father's from Georgia. Donald's mother was a postal supervisor and his father worked in the Navy as a civilian. Donald was the first in his family to pursue a medical education. He attended public school throughout his educational journey, graduated from high school with about 700 other students, and he started college at Howard. He then returned home and attended the University of California, Berkeley, where he graduated with a double major in biology and psychology and studied German. His mother had diabetes for 10 to 20 years before he found out. And he shares that people from Louisiana are incredibly good at keeping secrets. Donald originally intended on majoring in anatomy and going to grad school to teach. But when his mother told him that she had diabetes, he thought it meant that she would die soon. And at that moment, he decided to become a doctor. Since then, he's led in 10 areas within medicine. Our next speaker is Megan Mahoney. She's a professor of medicine in the Division of Primary Care and Population Health at Stanford University, and also the chief of staff at Stanford Healthcare. As chief of staff, she provides oversight of quality, safety, and professionalism activities for over 3,000 medical staff within Stanford Healthcare. For the last 5 years, she served as the chief of primary care, where she led primary care, precision health, equity, practice transformation, and population health initiatives for the network of primary care facilities practices at Stanford Healthcare. And before joining Stanford, she served in several leadership capacities in clinical operations, medical education, and research during her decade as a faculty member at the University of California, San Francisco. She was a Kenyan Ministry of Health advisor and also a visiting professor at the Aga Khan Medical College of East Africa. Dr. Mahoney specializes in innovation and transformative approaches to proactive and personalized team-based primary care that empowers patients, health providers, and communities in the United States and internationally. And our fourth speaker is Dr. Harlan Pinto. He's an associate professor of medicine and otolaryngology. He conducts clinical investigations that focus on head and neck cancers with a particular interest in combined modality therapy. As a member of Stanford's Eastern Cooperative Oncology Group trial efforts, Dr. Pinto is involved in the implementation and development of a variety of clinical trials at Stanford and the Palo Alto VA Medical Center. And so as you can see, we have quite a powerful panel with us today. And what we'll do is ask them 3 critical questions about their general research focus, specific research projects of interest, and their personal journey to their research focus that affects the Black community. And so we'll begin with Dr. Baraka Floyd.
Thank you so much for this opportunity to share with you all today. As I begin to share my slides, I'd actually like to start out with my origin story in medicine. I attended Morehouse School of Medicine, a historically Black college and university in Atlanta, for my MD and Master's in Clinical Research. My education there really confirmed my desire to work with underserved populations and the value of community. Also, being in company of all of that Black excellence was such a formative experience for me. When I did residency here, I'd actually planned to pursue pediatric endocrinology, but during my gap year, I fell in love with general pediatrics. And what you see here is our social screening board at Gardner-Packard. This is really the result from a clinical encounter with the parent who asked to speak with me privately. She'd shared that she wanted to be excited for a pregnancy, but she couldn't be. Her family couldn't afford another child. And this, in combination with so many other conversations with families, led us to pursue a community asset map of San Mateo and Santa Clara counties to build out social determinants of health screening, response, and follow-up, guided by families. We now are able to screen every family who comes through our doors for social determinants of health needs and provide trusted resources. So what I learned from this, I'd like to highlight 3 key things. First, pediatricians are really uniquely suited to address social determinants of health, but how we screen is as important as the questions we ask. Because social determinants of health screening takes into account the whole family, a holistic approach really is required. You need to align with families' priorities and partner to address barriers. Also in medicine, we're not equipped to manage social determinants of health needs on our own. I don't think that's surprising to anyone, but it makes collaborations with partners outside of the healthcare system, inclusive of respect for their expertise, crucial. Responding to community identified needs was the biggest lesson here. Families helped to start and finalize this community asset map, only deepening my commitment to community engaged research to respond to community needs. And so that led me to a focus on cross-sector partnerships, like medical legal partnerships, early childhood systems like First Five, for example, and community-based organizations like core service centers to really implement interventions designed to address social determinants of health that are grounded in person-centered interventions, recognizing the expertise of families in their lives, identifying not just challenges, but strengths to call them out for families and use them to support resource provision and follow-up. The next study I'd like to highlight is DULCE, which is an acronym for Developmental Understanding and Legal Collaboration for Everyone. The DULCE approach grew out of a successful randomized control trial, and we expanded this using quality improvement to implement DULCE in a first cohort of 7 diverse communities across California, Florida, and Vermont. And what this does is adds the DULCE interdisciplinary team, which is composed of a family specialist, MD or NP, a mental health and early childhood representative, a legal partner, and a clinic administrator. And so I'd like to play a short video illustrating how DULCE creates family-centered systems of care.
Welcoming a new baby is joyful. It can also be stressful. Racist and inequitable systems make it hard for families to access resources like food or stable housing and figure out a confusing healthcare system. DULCE can help. How? A family with a newborn is supported by a family specialist on their parenting journey and is connected to the resources they need. The family specialist identifies needs alongside the family, like housing, food, or mental health, and then collaborates with an interdisciplinary team to come up with solutions. The family specialist offers solutions directly to the family, who decides what's best for them. Navigating these systems alongside families lowers their stress and gives them more time and energy for their baby. Families graduate from Dulce with more resources and more confidence navigating the health system. Hooray! To learn more, email dulce@cssp.org.
So a recently published paper in Pediatrics highlights how the Dulce approach, using processes that are tailored by local cross-sector teams, results in high screening rates for families that have multiple needs with high rates of resource provision for concrete supports, maternal depression, and IPV. I learned so much from working with the Dulce team, but want to highlight a few things. The cross-sector team case review really allowed for teams to identify patterns. And so this was able to accelerate advocacy to address system gaps. For example, speeding up infant enrollment in Medi-Cal. The Dulce approach is grounded in support through trusted relationships, honoring the parent as the expert on building as the expert to build existing strengths, And this lifted up the value of relational health approaches as we approach social determinants of health needs. Partnering on these interdisciplinary cross-sector teams really grew knowledge for everyone at the table. And so as I watched these teams work together, each partner started to begin to contribute points outside of their sector. The next steps in this work are further dissemination of the findings from the second cohort. For my community engaged research work, I'd like to highlight Diapers at the Doctor, a program founded by Dr. Janine Bruce and me. You may wonder why we're talking about diapers, but in our local area, because of unparalleled income inequality, it's even more important because all babies need diapers. They're expensive. They take up nearly half of the income in single parent homes. And diaper insecurity, or the inability to afford enough diapers to change your child as often as you need, can cause problems like diaper rash and UTI for babies and emotional stress for caregivers. In 2016, pediatricians were starting to notice just that families didn't have enough diapers to change their child often enough to prevent problems like diaper rash. And we were ready to act. So with the inspiration of an Obama White House program to address diaper insecurity, we partnered with clinic leadership and clinic staff to leverage a gift funding from LPCH. And then we were able to provide 20,000 diapers to 201 families. Our needs assessment identified that only 40% of families have adequate diapers, with price as the primary barrier, and that our families didn't have access to diaper banks. And so even after this pilot, families, clinic staff, and pediatricians continued to inquire about when we'd be able to bring Diapers at the Doctor back. Given this pressing need, Dr. Bruce and I continued to work on just that. And by 2020, we were able to make Diapers at the Doctor a weekly diaper distribution program, making this a reality. So our Gardner patients who are of diaper wearing age can come, receive 100 diapers per child per month. And our program is staffed by student volunteers, with our Gardner Packard staff actually often coming over to join the distribution and provide input on operations. To evaluate the program, we're collecting survey data to capture the impact of the program on diaper, financial, and food insecurity, and interviews to capture caregiver perceptions of the same. And our team and Gardner Packard staff continue to regularly explore ways to improve the program. Some brief insights of what we've been learning in our interviews is participation in the program really alleviates diaper insecurity. What this caregiver is stating, before I had to get money for rent, get money for electricity, and still get money for diapers and wipes. And now, well, honestly, we only buy wipes and food and electricity. In other words, having sufficient diapers is one less of a concern. Receiving diapers also impacts caregiver well-being, with this caregiver stating that she's happy because Diapers at the Doctor has helped reduce stress, and she's not worried about having to buy diapers. Despite Diapers at the Doctor being conceived as a service to our family, data collection and evaluation were obviously essential to prove program impact and sustain this service for our families. Being able to hand a family diapers and see the stress melt off of a parent's face is such an amazing privilege. And building and managing the team of student volunteers has really provided lots of leadership lessons for us in vulnerability. The program is essential. It's like running a store, which Dr. Bruce and I don't have experience in. So our student volunteers and our clinic staff's innovative ideas were really essential to being able to operationalize the program. They weighed in on everything from inventory to tracking program participation. And it's really something that our entire clinic staff also owns along with us. Our goal is to spread and scale this program, first to some of our local collaborative clinics and then beyond. I'll stop there, but thank you so much for the opportunity to speak with you today.
Thank you, Dr. Floyd. I appreciate you sharing your research with us and your journey as well. Next, I'd like to turn it over to Dr. Golden. And Dr. Golden, I believe you're muted.
Can you hear me now? Okay. Thank you very much. I work with Roots Community Health Center. I'm faculty here at Stanford, and my general area of research focus is equity in healthcare, mainly in the primary care setting, but we think it can be applied in other areas of healthcare also. The specific topics we have a model of healthcare for the underserved community, again, that we think is applicable in many different areas. The way we look at this is, or proceed is, we're looking at technology and students, interns, and residents. Our model is unique. Primary care settings, are usually just one primary care physician. We're fortunate enough to have interns and residents from Kaiser, OBGYNs from Santa Clara Valley Med, and access to technology. What this does is, instead of the normal standard primary care model of seeing patients every 3 months, we see patients every week, and pretty much for our underserved patient population, a month doesn't go by without seeing a patient. Also, with this particular model, healthcare has sped up for many different reasons, including technology. Some of our students are able to take up to 2 hours per visit with a patient. And so this provides intense education so the patient can be an informed consumer. Once the patient becomes an informed consumer, then they can be a more active participant in their own healthcare. We're noticing, that after about a year, it seems that our patient population is receiving similar benefits as if they were in a for-profit organization. Okay, good. Other things are we're affiliated with approximately 45 nurse practitioning universities. They are part of the power of our clinic. We have had several of those individuals go on to obtain their doctorate using data through our clinic. There is an individual right now that's in the process of doing that. We've also have applied to several different Stanford programs in hopes to obtain funding to crunch the numbers of our clinic. We're running a primary care clinic, and that exhausts all of our time, energy, and efforts. And so with additional funding, we're hoping to acquire hardcore researchers to come in and crank out more of the numbers that we're producing. Let's see here. Good. Okay, so there's another aspect to our program. and that is vaccination and testing. Our underserved clinic has vaccinated approximately 14,000 individuals in the underserved community. So that has been extraordinarily impactful. We're acquiring, again, a lot of data on that. We were processing at one time. Patients would go through our entire pop-ups in 4 minutes. And so again, we're hoping to acquire more funds to crunch those numbers. My personal journey, I've been doing this for about 30 years with patients. About 20 years, I've been teaching students and patients to optimize healthcare in the underserved community. I've worked in many different settings: ER, hospice, hospitalist, for-profit, nonprofit. And my goal the entire time is it always bothered me that it appeared that people in the underserved community did not get as good care as people in the for-profit community. So my goal is that I feel care should be, precisely the same for every individual. And our model strives to do that. We feel that we've been extraordinarily successful. When I started out about 15, 17 years ago in one of my primary care settings, we were able to see 60 patients, up to 60 patients a day. I being the sole physician, and UCSF, UC Davis, St. Omer University would send their students to help us out. And so that model has been extraordinarily refined with the help of Roots, Kaiser, Santa Clara Valley Med, and Stanford. We have gotten extraordinarily good recognition from Santa Clara County. We started out at this clinic in Santa Clara with 1 or 2 patients. Now we have 1,000, and they appreciate the clinic in general. But we've been able to keep a great deal of these patients out of the ER. They are no longer frequent flyers there. Again, with this funding that we feel will be coming soon, we hope to standardize a model that will be able to be used anywhere in a primary care setting. That's our goal. And that's my story. Thank you very much.
Thank you, Dr. Galt. That was a fantastic story. So thank you for sharing not only your personal journey, but how your personal work turned into a program that's serving the community. Next, I'd like to turn it over to Dr. Megan Maloney.
Hello. Good. Yes. Yeah. Thank you. Good afternoon. It's so great to see all the folks who have called in, and it is really an honor to share the stage with my colleagues here. What I wanted to go through today was a couple of slides, so I'm going to try to share my screen here. Sometimes the screen sharing doesn't work for me on my computer, so let's see. But I thought I would just chat a little bit about my background and the research that I have done in the past in health equity, particularly among African-American communities, and then how that feeds into my leadership now. And so tell me if you can see my screen now.
Yes.
Okay, great, thank you. So my career, well, just a little bit about my background. So, my parents were very active in the civil rights movement. Social justice is something that we talked about at the dinner table on a regular basis. My mother has been an academician working in historically Black colleges and universities throughout her career as a mathematician, and then later in the administration of universities. communities. And so I've always been inspired by what academic settings can do, specifically academic medical centers and all of the inspiring work that we're all doing every day. And my particular journey started in social justice as it intersects with medicine when I was working in this clinic at the Family HIV Clinic at the San Francisco General Hospital. And since we don't have a lot of time, I just wanted to mention one big takeaway that I learned when I worked in this multidisciplinary clinic, serving not only those who are living with HIV, but the entire family affected by HIV, including children and who individuals defined as their family. One of the big lessons I learned when I was working in this community, conducting research, looking at the most effective ways of lowering viral loads, engaging specific communities, is this person who's sort of right here in the middle. And that was our social worker, and how we were able to effectively address the social determinants of health, because our social worker was the hub of our team. And that at that very early stage in my career, I appreciated the important value, the important role that team-based care has, and have been, I try to be a champion of team-based care throughout my career. I also was able to conduct research in a place called the National HIV/AIDS Clinicians Consultation Center. This is a CDC funded service that provides a plethora of services currently, but when I started, we were focused on HIV, reduction of HIV and maternal child transmission, HIV and co-infection with hepatitis C, and then pre-exposure prophylaxis after a needle stick injury. And what I liked about this is we were able to access rural communities, urban communities where the level of subspecialty care in HIV was not available. And through a simple phone call, we were able to walk providers through the treatment of a pregnant woman with HIV and ensure that she did not transmit HIV onto her children without a subspecialist. And so this was a way to augment access to care across the United States. The research I did related to the topic of today, I'll just highlight one study that we conducted, which was we accessed the records of all of the African-American patients that were treated and providers who contacted us about their HIV care. And then we asked, we looked at the quality of care, meaning what was their viral load, and then looked at the composition of the team that was taking care of them and looked at their racial makeup. And what we concluded in that study was that when an individual who is African-American was able to have a care team that looked like them, where they felt that they could trust the team that was giving them the care, when there was racial concordance, at least with one member of the team, a social worker or a pharmacist, there was a lower viral load associated with that. And so that's one of the published studies. And I know that we have been seeing more and more studies that also show that racial concordance is a powerful part of care, if possible, between provider and patient. The telehealth was extended when the California healthcare the California state prisons went under federal receivership because of a preventable death that was occurring in the prison system every week. And I was just so happy to be able to be part of the team that the CDC, or the California Department of Corrections, contracted with in order to overhaul the healthcare that was being delivered in the 33 state prisons. We did that largely through telehealth. This wasn't the telephone. We actually did do it through video visits. And then we also visited individuals in prison when needed, when in-person care was indicated. And my assigned prison, I've been to most of them as part of the review process, chart review process, and rebuilding the teams, coming up with the protocols. But my prison was in Chowchilla, California. And you can kind of see here, if you look closely, it's right in Central California, close to Fresno. I visited there every month, took care of women who were incarcerated there who had HIV or hepatitis, and transgender care was also an area of expertise I was able to bring to that setting. And lots to say about the experience there, lots to say about, for example, the problem that we have in the state of California and across the United States regarding our mass incarceration and how that affects African-American communities. I saw it with my own eyes, and I think we all are very aware of this. You can see the effect here of the 3 strikes legislation that went into effect in the state of California right around the time when Reagan was leading the war on drugs. And so this mass proliferation of prisons and prisoners, it's an ongoing issue. I'll just throw out a few more data points here. We are leading, the prison I went to was the world's largest women's prison. When you look at an incarceration rate globally of 165 per 100,000, we are at 629 per 100,000, and this is data I just got from this morning. So this is current data. We really do have a problem, and I think we all are understanding more and more the structural reasons for this. And just so delighted to be working with individuals who are committed to this work. When I was there, the prisons were also facing massive overcapacity, with double and triple bunks being stood up in the what used to be the gymnasiums. And so as we start thinking about communicable diseases, we start thinking about our most recent pandemic, it is quite clear how the public health risks are very hard to mitigate in these environments. So I became interested in not only how do you deliver high quality care when you were looking at the geography that we were looking at, these prisons being situated in very rural areas, having a shortage of specialists, looking at how to provide those specialty services in that environment. So that was an area of research for me. But in addition, I became interested in the communities that were being affected by this high rate of recidivism, going in and out, particularly the women who have partners who are involved in the criminal justice system. What is in my area of research is HIV prevention, what is their HIV risk? And was funded to work with community-based organizations in San Francisco, and then also community-based organizations that were associated with the prisons we worked at in order to reduce the risk of HIV transmission. I just have some slides here just about, the healthcare issues of when we are focused on punishment over care. We can see that this would be problematic for someone who is dependent on oxygen and there's no monitoring of them. We can see that when someone has a fractured arm, this is probably not the best position for that arm to be in. And this is just some information about the HIV prevention program that I was a PI for. And then most recently, I spent 2 years in Kenya, in Nairobi, Kenya, and I was a family medicine residency program director there, but we also were thinking about ways, again, to spread the impact of healthcare through teams and technology, so that we could meet the healthcare needs of a population that had poor access. And so there was a public-private partnership between the university I was working at, Aga Khan University, and Ministry of Health and the public health system to provide primary care in these rural regions. And we called it the Integrated Primary Health Care Program. This is an area where there wasn't a universal healthcare record, and there was often a lot that was lost in translation when you went from one level of care to another level of care. So we bridged the gap between the district hospital and the health center, and then also to the home. And our family physicians, the residents, would go and visit home. And what a wonderful way to learn about social determinants when we go to the home. So this is just some of our trainings with the nurses. This is our community outreach event. We treated nearly 1,000 patients that day, measure their hypertension. And then we learned about how foodborne illnesses are so easily transmitted in an environment where we understand where the water comes from, where food comes from, and then just sort of the environment in the home. This is a mosquito net. This is also one of my favorite slides because earlier we heard from Dr. Floyd about diapers. And when we go to the community and ask them what they need, they tell us what they need. They need diapers, and it's not what we first think of. And similarly, we have that experience where these are mosquito nets for malaria reduction, but you know what they were using them for was a chicken coop. And so it's like, oh, that's what they need. They need economic prosperity. They need to be able to, secure their economic security before they start thinking about reducing their risk of malaria. This is an area that had an unmet a reproductive contraceptive need area. So large families here. And right in the back, you can see that this is one of the family medicine residents who was visiting. And when she went out and visited, she was visiting with a man who did not come in for his directly observed therapy for tuberculosis. Like, okay, are you okay? You didn't show up. And he said, I'm fine, but she's not. And he was pointing to his daughter, who ended up having cerebral malaria, and we ended up having to take that daughter in. So importance of having contact at the home, understanding what's happening outside the walls of the clinic. And I do try to bring the experiences I've had with effective community partnership and engagement, the role of teams and technology in extending our reach outside of the walls of the clinic, and then getting to the home to understand social determinants of health and all that I do. Thank you.
Thank you, Dr. Mahoney. This is, I think we're leading up to a great question and answer session. Just as a reminder to everyone participating that we'd love to have your questions for the panelists. And you can use the Q&A function that's at the bottom of your screen to provide them to us in advance so that we can prep them for our panelists. And with that, I'll lead into our final speaker, who is Dr. Harlan Pinto. I'll hand it off to you.
Thanks a lot. And so I'm going to share my screen. Hopefully that'll work. I do have some slides. I can't tell what you guys are seeing. Do you see the slide? Yes? No? I can't.
Yes.
Yes.
Slide. Perfect.
Perfect. So I just want to talk about a little bit of the prompts. So I just wanted to describe kind of my general research focus, my specific projects of interest, and then a little bit about my personal journey. So my general research focus is cancer clinical trials, and I focus on head and neck cancer, a cancer that has had in the past a black-white disparity in outcomes, not necessarily incidence, but outcomes. In the past, it's reflected smoking and drinking behaviors. More recently, head and neck cancer has been associated with the HPV virus. And so that neatly intersects with vaccine issues because there are HPV vaccines. A big part of my head and neck cancer work has focused on cancer clinical trials. And I really have spent quite a bit of time looking at health equity in cancer clinical trials participation. I'll get into that a little bit later. Now, my specific research project of interest at the current time is a Navigate clinical trials program, which is a NCI collaboration to increase VA and veteran participation in cancer clinical trials. So I'm going to get into my personal journey, which involves education, training, mentoring opportunities, and a lot of experiences. So as a background, I did my undergraduate work at Brown University, and it turns out Dean Lloyd Minor was in my class. It's kind of interesting. You can see his path, you can see my path. But anyway, he was a great guy, and we're fortunate to have him as our dean. I studied biomedical ethics in college, and my thesis was on the physician-patient relationship. And subsequently, I actually did a little research on the long-term impacts of chemotherapy on childhood cancer patients. That was a little bit of a kind of wake up to maybe cancer might be one of the things that I focused on. And I left Brown and went to Yale School of Medicine. My thesis there was guidelines for the use of placebos in clinical research. And so I really had an interest in clinical research way back in medical school. In medical school, I had the opportunity to work in a very supportive environment in New Haven. I had family in town, and I was able to do a short stint at the Family Studies Unit at the National Cancer Institute. I did a hematology oncology rotation at the University of West Indies in Kingston, Jamaica. And I did a primary care clinics rotation in St. Croix in the US Virgin Islands. At that point, I had an insight that there was a lot of obesity in the US Virgin Islands and virtually none in Jamaica at that point. So it was kind of interesting to see kind of the environmental impacts on health issues. Subsequently, I went to the Mass General in Boston for my residency in internal medicine. And I was able to serve for a year on the MGH Harvard IRB, or the Institutional Review Board, looking at research proposals. Following the NCI, I did a National Service Corps stint in primary care in a community healthcare center in Cleveland, Ohio. It was the Northeast Ohio Neighborhood Clinics, and that was great because I did primary care. I learned how to do it. It was a lot of fun, and it really was inner city Cleveland. And I felt like I really had a big impact. Of course, I had a lot of cancer focus, so I actually set up a screening colon cancer clinic when primary care doctors used to do sigmoidoscopies. This is like ancient history, okay? But I was able to do that, and that was actually lots of fun. And then I came to Stanford for my medical oncology fellowship, and it was great here. I mean, I actually was able to really focus on a lot of my interests. So next slide. So then I was a medical oncology fellow here. And in 3 years, I then joined the faculty where I did lots of research, teaching, and patient care. And I located my practice both at Stanford, where I mostly had a head and neck research clinic, and at the VA Palo Alto. Now, it turns out the VA is a special place in general. I'm not sure if people understand, but there are very few health disparities based on race in the VA. There are lots and lots of studies that show there are really no disparities. And there are a few that show that there's some. And all I can say is 30 years ago when I came to Stanford, my experience at Stanford was I had really no minority patients, very few, less than 2%. However, the VA in our environment is much more diverse, where about 16% of the patients at the VA are from ethnic minorities. Having said that, the VA is committed to being the trusted partner for healthcare. And what that involves is that all our patients get a social worker, a nutritionist, the chaplains are around, and they really do support transportation to break down the barriers to get good health care. I think those things actually help, and they help a lot, as well as our clinics at the VA in oncology for sure have psychologists in the clinic too. So they really help us address all the issues that go around having cancer and getting treatment. One of the other things when I started was I became the study chair for a national study using chemo prevention to prevent head and neck cancer. And I also did an investigator-initiated study here at Stanford that looked at chemotherapy for organ preservation in head and neck cancer. That involved giving chemo so that you could avoid a laryngectomy. And that's kind of standard treatment now, years later. But in 1993, as part of my Eastern Cooperative Oncology Group work, we did the ECOG Minority Accrual Initiative. And then in 95 and 96, I became the chief of oncology at the VA Palo Alto, and then the ECOG PI for the entire Stanford main member institution. Now, what happened at the VA was when I was chief, I was able to promote clinical trials more. And then my work at Stanford had me with 9 affiliates throughout the state of California, really trying to get clinical trials participation kind of through a network of local institutions. Going backwards a little bit, the ECOG Minority Accrual Initiative involved me and some of my partners doing focus groups in 4 cities where the catchment area demographics suggested that there were barriers to the participation of Black patients in NCA-sponsored clinical trials. So in general, the clinical trials enrolled about 3% of eligible patients, and the numbers for Black patients were incredibly low, so low that the NCI decided to make it a condition of the grant that you addressed how you're going to improve minority accrual. So what ECOG did was we did these focus groups, and we picked 4 cities where the demographics were out of balance with the people that they were enrolling. I'll just say that. And then what we did was we involved community primary care physicians affiliated with the NMA and ECOG main institution physicians. Those were the people at the university. So we had them meet and we explored participations of how they could like understand or get more participation in clinical trials. And the focus groups showed that there was a lack of information about the available trials, what the safeguards were, what consent forms were there, the resource issues. And so following up, I wrote with some of my partners an editorial in the NMA Journal suggesting that participation in clinical trials was state-of-the-art treatment for people of color. I did a lot of updates at the NMA meetings. While I was getting my ACLS every 2 years, I'd make sure I'd go to the NMA meeting and give a talk here and there. We presented the ECOG initiative, and then subsequently, and there were a lot of work and cancer updates, what's new, those kinds of things, to keep myself involved in that group. But more recently, I've done a couple things with the NMA in terms of participating at a community forum where community members came and I was a cancer expert just asking questions, as well as presenting on HPV and cancer. And it turns out that this allowed me to address vaccine issues because you can prevent throat cancer, head and neck cancer, tonsil cancer, and cervix cancer for women with the HPV vaccine. And so those are my NMA activities. Now in ECOG, there's an NMA advisory board that became a permanent part where we basically worked with one of the Region 2 NMA group, and primary care physicians actually became ECOG investigators in a breast cancer prevention trial. That was really quite remarkable. And basically that advisory board supports NMA members going to ECOG meetings, and those NMA members basically have a seat at the table in the design and the promotion of the clinical trials that get developed. Now there is an NMA ECOG Health Equity Committee, and now they're NMA scholars, and they've had 26 scholars. So these are students that actually get funded to go to the ECOG meetings, again, to understand what cancer research is all about. And basically, that's been actually a lot of fun too, because you get to see a lot of young people. And I would only say to this group, if anyone wants to go to the ECOG meeting, let me know. I'll put your name forward. They actually fund. You can have fun at the meeting. There are some Bay Area activities, and I would only say that I've been on the American Cancer Society Cancer Santa Clara County Board of Directors. There's an African American committee. There have been several presentations. I think one of the things that was interesting is I found myself on the street at a kickoff campaign for Prop 29, which was the $1 a pack for cigarettes. And so I hadn't been at a street function in a long time, but I got a lot of kick out of it because we were really out there. And recently I've been involved in this program, 50 Hoops, which are cancer-related webinars that are community focused that anyone can kind of sign up and join. So that's been interesting. It goes from meetings to kind of internet stuff, and it's kind of interesting. The last thing I wanted to say is we've got this Navigate Clinical Trials program, and the bottom line is we're trying to enroll patients in clinical trials, ensure diverse participation. And the main thing about these clinical trials is that it actually is technology transfer. In order to do state-of-the-art trials, our institutions have to change, and we have to change, and we have to accommodate patients. So it's actually very rewarding. And with that, I'll stop. I do have a little bit of a bibliography for some of this stuff. I'll just put that up quickly, and I guess I'm done. Thanks a lot.
Oh, thank you, Dr. Pinto. This is great. We have just a few minutes here at the end of our session to be able to transition to question and answer.